Hi, I'm Gabriella Trees, and I'm doing my poster presentation on the role of nuclear medicine in neuroblastoma. And I decided to choose this topic because during my clinical rotations at Cincinnati Children's, the neuroblastoma kids were frequent flyers in the department, and all the techs had really good relationships and treated these patients very well. So it just kind of had a special place in my heart. And it's not as known as in the adult world, especially in nuclear medicine. You don't see this, it's only in children. So I think more people should be educated and informed about this topic since they are unfamiliar with it, unless you are working in pediatrics. So to start off, I just wanted to give a brief introduction and background about what neuroblastoma is. So when we're looking at the diagnosis, and what neuroblastoma is. Neuroblastoma is a malignancy found in infants and children arising from the cells of the neural crest. And the cells can be found in the adrenal medulla or anywhere in the paravertebral sympathetic chain. And this is known as a neuroendocrine tumor. And when we're looking at how old these kids are when they are diagnosed, 90% of them are 1 to 5 years old, and the median age is around 18.8 months. So again, they are usually very young. And when we're looking at the prognosis of neuroblastoma, it's not great, but it has improved over the years, which is good. And why, again, this topic is very important, and research is always needing to be done and improving scans and treatments for these kids. The neuroblastoma approximately accounts for 13% of all pediatric cancer deaths. And the diversity of these tumors range from patient to patient, vary on a broad spectrum. So they can be from spontaneous regression and all the way to spreading throughout the body and metastasizing. And then when we are looking at the survival rates are under 50%, and that is despite multimodal therapies. So again, why we want to improve research and keep this topic in everyone's heads. So for this research and literature review and poster presentation, research was conducted using online databases to gather information and studies on this topic. I mainly use PubMed and CINAHL, and they gave me reliable peer-reviewed articles. And the keywords to search these articles were neuroblastoma, MIBG, iodine-131, iodine-123, and 18-FFDG. So when we're really looking in the meat of this topic, it's about the nuclear medicine imaging. And there's two main prospects when we're looking at nuclear medicine imaging with neuroblastoma. One, the radioiodinated MIBG scintigraphy, and the PET-CT. So just a background for those who don't know what nuclear medicine is. Nuclear medicine is an imaging modality that uses radioisotopes to detect the physiological functions, and it also has some treatment and therapy doses in there. So nuclear medicine actually does play a pretty large role in the neuroblastoma kids, but there are also other modalities that I will not be covering in this presentation. And when we're looking at the gold standard and the #1 nuclear medicine procedure and scan, it is going to be the MIBG scans. So those can be labeled with iodine-123 or iodine-121, and those image the adrenal medullary tissue. And whole body scans can be done, SPECT CTs, and planar imaging. And the SPECT CT is a single positron emission computed tomography, and it basically is like the CT form of nuclear medicine and is really honed in on one area, the area of interest that we're looking at. So typically, a typical protocol would be a whole body scan and then a SPECT of the area of interest. And SPECT has really good benefits over just planar imaging alone. So really planar imaging isn't used too much with the MIBG scans. And it's 80% more specific in detecting the localization of the tumors and gives a lot more detail. And like I said before, it is the gold standard to diagnose, stage, monitor, post-treatment of the neuroblastoma kids. And then we're looking at the doses of the MIBG given for these kids. They have to be kept at a minimum, and we follow the guidelines of the Northern American Conscious Guidelines or the European Association of Nuclear Medicine dosage cards. And typically it's 0.14 millicuries per kilogram with a max of 10 millicuries. And it's also important to block the thyroid because the iodine will uptake in the thyroid if we don't do so. So when we're looking at the PET-CT, PET-CT is useful to image non-MIBG avid tumors, which is around 10%. And PET-CT primarily uses FDG, radioactive glucose, to inject and those uptake in all tumor cells. But there is new research and it's looking really promising for the neuroblastoma cases such as dotatate and DOPA isotopes. And when we're doing PET-CT, usually the kids have to have a MIBG scan first, and then they would be referred to PET-CT. And to circumstances, they must have MIBG negative or weakly positive tumors, or if the radiologist or doctors think that the disease is more extensive than what the MIBG scan shows, then they would be sent for a PET-CT scan to possibly see tissues and cancer cells that weren't seen on the MIBG scans. So when we're looking at the images down here, it is of a 3-year-old girl who has, unfortunately, has neuroblastoma that has metastasized. And on the left there, those are going to be your PET-CT images. And in this case, she did have cells that were not picked up in tissues that were not picked up on MIBG scans, as you can see there on the left side, the arrows are indicating. And then the typical MIBG scans here, and SPECT-CT is on the right side. So when we're looking at our next pictures down here, that is comparing our iodine 131 to iodine 123. So iodine 131 was first approved by the FDA in 1994, and then iodine 123 was approved in 2008. So iodine 131 was the only isotope at first, just kind of how there's more isotopes coming out that are better and more efficient with less radiation dose. That is how iodine 131 first came out. And that is now why we only use iodine 123 for imaging, is because it has a much less radiation dose to the patient and also has less beta emissions, which protects the patient and the staff, and also leads to better image quality. So as you can see on the left here, there is a lot of noise in background. It kind of looks fuzzy, and that's because of the high radiation dose leads to background and image noise and scatter. But you get a much clearer image on image B right here because of the lower dose. And although we primarily use iodine 123 to image, some research has showed that post-therapy of iodine 131, that imaging of iodine 131 is useful because it picks up residual tissue that the iodine 123 has not. So when we're looking at figure 3 here, that is how the MIBG scans are interpreted by the semi-cognitive scoring. So on the left here, we have the Curie scoring, and that has 9 segments. That is section F2 that they look into, and a 10th segment for soft tissue. Each segment is labeled 0 to 3, 0 meaning there's no disease. And then 1 has 1 lesion, 2 has 2 or more lesions, but still less than 50% of the involvement. And then 3 has more than 50% of the involvement of the region. And then that SOPEN is on the right here. And that has more segments. It has 12 segments, and the scale goes from 0 to 6. 0 to 2 are the same. So 0, no involvement, 1 some lesion to 2 lesions, but less than 50%. But then we're looking at 3. 3 is 3 lesions, and then 4 indicates diffuse disease, but still less than 50%. And then 6 is greater than 90, less than 95% involvement, or sorry, greater than 95% involvement. So that is how they interpret the MIBG screens and see each segment of the body and score them based on that scoring system. So after all imaging is done and the radiologist, doctor, and patient care team has indicated what's the best course of treatment, usually multimodality therapy is recommended, and part of that is the iodine 31 MIBG therapy. And it is very extensive therapy. Lots of pre-work has to be done to make sure that the patient is getting the optimal dose and doing all the pre-test and everything is clear to go. And once it is, they, like I said before, they find the optimized dose, and they can do that by finding a fixed amount, weight-based, or calibrating to a full body dose. And it seems to be very effective. The largest phase 2 trial showed a 36% response, and it's only increasing from there as the diagnosis are found earlier. So in a study, 66% response rate was found in newly diagnosed patients after 2 cycles of treatment, which is great. But again, like I said before, it's important to complete kidney tests to make sure the kidneys can wash out the radioactivity since it is secreted through bodily fluids, and then complete the blood work to make sure the hematological effects are not going to be too much and make the symptoms worse than they were before. And then just like we are protecting the thyroid with the scanning, it is very important to protect the thyroid with the treatments and do a pre-dosing for that. And then lastly, the radiation protection and isolation is essential, not only for the patient, but for the family members, staff. And most of these patients will have to go to the inpatient room that is covered in sealing or sealed in paper, absorbent paper and plastic. And there's lead lining on the walls just to ensure that no one is getting unnecessary radiation exposure, and then they are released when their radiation exposure given off is okay for them to be around people, and just making sure that the bodily fluids are good and the urine is going directly in the toilet and good stuff. So another research study found that the radiation dose and hematological side effects can be decreased with the use of stem cell rescues, and other side effects are nausea and vomiting. So when we're looking at the limitations of all these research and findings, there are many aspects that play a role in neuroblastoma patients, and nuclear medicine is just one of them. And like I said before, the cases are extremely different. They are not one in between. So it's hard to compare them, and pretty much every factor is going to be different when you're looking at each patient. And then the MIBG therapy is still relatively new and it's still under research protocols. And then radiation exposure with pediatrics in general, but especially with these MIBG treatments and dosing, we want to keep that to a minimum. So it's important that if it's working, then that's great. But if it's not, then we're not going to continue with it if they're not seeing good side effects. And each institution is going to have a different protocol, so that limits the comparison again from study to study and image to image. But overall, the conclusions are that the neuroblastoma stage and tumor avidity are important factors in every case in study. And then iodine-123 yields better image quality in the radiation dose to the patients. And it is the gold standard. It's the first line of imaging when a patient is diagnosed with neuroblastoma. And then MIBG is most effective with the use of other therapies. And then overall, the main thing taken out of all of this is that prevention and early diagnosis, especially with neuroblastoma, is a very important issue in pediatric cancers. And it is going to be very important to do that so we can get the best outcomes possible for patients. Thank you. And let me know if you have any questions.